Okay, so now let's talk about how to present a patient in about 3 minutes. Now what most people are going to do is, after talking to their patient at the bedside, doing your evaluation, most students, residents are going to come straight to the attending and present right then. Usually these presentations are disjointed and then completely loses the attending, and then you also lose our attention as well. So instead, I'd suggest, why not, after leaving the patient's bedside, sit down and take a moment to organize your thoughts. And then you can come and present a very well thought out, focused patient evaluation and plan. Now, we already know from our prior videos, when we approached a patient, we looked at a couple of things. The first thing that we did was we formed a differential diagnosis that included all the killer life threats. The next thing that we did was assess the patient's primary survey and perform any initial actions that need to be done. That included putting a patient on an IV O2 monitor, getting an EKG, and possibly a pregnancy test in women. Then at this point we would start our history and physical, or our secondary survey, once we've established that the patient wasn't going to die, by making sure the primary survey was intact. And here we would do a nice focused history and physical, and that is guided by our differential diagnosis. After this, we would revisit our differential given the new information we got from the secondary survey, and assign our pretest probabilities to the diagnoses in our differential. And then finally, based on how likely all of the diagnoses were that we established in the step before, we would decide which tests we want to order. So time for diagnostic testing. So if you follow a similar paradigm when you are presenting your patients, what you will end up doing is follow the same thought process that we are using, and so we're just going to be on the same page, and you're not going to lose us. And so now I'm going to describe what you say, and then correspondingly what we are thinking when you say that. The first thing you're going to do is allow us to form our differential diagnosis, and that is our anchor for the rest of your presentation. So in order to do that, we need the same information you use to form yours, and that's the chief complaint, the age, and the gender. So you might say, this is a 57-year-old male presenting with chest pain. So when you say that, we think of our differential diagnosis. So those killer chest pain things are going to pop into our head right at that point too. So you should lead with the chief complaint, age, gender. So the next thing you normally do is assess the patient's primary survey. And so when you're going to present this patient, you want to allow us to get a feel for what the patient's primary survey was too. So what I would probably say is give a nice, maybe an interpretation of the vital signs, such as the patient was hypertensive, not tachycardic, was a little bit, the breathing rate was normal but was a little bit hypoxic. And then I might outwardly say what you thought about the airway, breathing, and circulation in this patient. And so you could say, I thought this patient's airway was intact. The breathing was not intact. They were hypoxic with a pulse ox of 88%, so I put him on 2 liters of nasal cannula, and I wanted to reassess. And I thought his circulation was okay as well. So now at this point, what we are thinking when you say that is, okay, good. The student thought about the primary survey, and the primary survey seems intact. And so now I feel comfortable listening to what else is going on. Now the next thing you would do is the secondary survey, the focused history and physical. And so you want to present this much in the same way that you took it as well. So remember, when you took the history, the first thing you did was get a 2-minute summary of the patient's reasons for coming. I would give a short summary of that, followed by your good description of the patient's complaint, so the cold read mnemonic. Follow that up with your pertinent positives and negatives, then all the past medical, social, etc., and review of systems. Now remember, you want to keep this brief and concise, yet thorough. So follow that method we discussed earlier. So a very quick description of what the patient said, a very good description of the patient's pain, the pertinent positives and negatives, and then the rest of the past medical stuff. So when you say that, what we are thinking, with that we'll say, oh, okay, that's why the patient is here. And when you give the good description of the chief complaint, the cold read mnemonic, we start thinking, oh, this really sounds like this diagnosis. So your good description of the pain starts allowing us to stratify our differential in our head. And the pertinent positives and negatives also help us stratify our differential. And your focused physical, again, should help me focus my differential as well. Now the next thing that you do is form your pretest probabilities. And so we'll wrap up all the pretest probabilities and diagnostic testing into one thing. We'll call this our assessment and plan. And I would start that with a 2-sentence summary of the patient's history and physical. Very brief, because you've already gone through it. This is your interpretation of the history and physical. And then I would go through every diagnosis in your differential and say what you think its pretest probability is, why you think it's that, and what you want to do about it. So you might say, for acute coronary syndrome, I think the probability is pretty high, and I want to get an EKG and a troponin and admit, because I think they need a stress test, even if everything's negative. For thoracic aortic dissection, I thought it was about medium probability, so I want to start with a chest x-ray, and if that's negative, I'm going to leave it there, but I might consider doing some other testing like a CT if necessary. My probability for PE is pretty low, so I'm going to get a D-dimer, and if that's negative, I'm going to stop there. So what you're doing in your assessment and plan is a couple of things. Number one, you are telling me your interpretation of the history and physical. You are showing higher order thinking. You're synthesizing the information you collected. You are telling me your differential diagnosis that you are considering, as well as what probability, pretest probability, you're assigning it, and why. So you could say, I think this guy has high ACS because the pain is characteristic. He's a smoker, hypertensive, and he has a strong family history of it. And then you're also telling me what tests you want to order afterwards, and therefore why you want to order it. You're not just ordering tests randomly. You have a reason why, and you're telling me right now. And the final thing that I would include in your assessment and plan is your best guess at the disposition of this patient. You could say, I think this patient probably will need to be admitted, or would likely go home if everything's normal. Now, it's okay to be wrong with this, but I'd still want you to make a guess. I want you to put your money down on some decision, because I want you to start developing that instinct, that ability to decide where a patient is going to go. This is akin to the thing that you're going to always hear us asking. Do you think the patient is sick or not sick? Again, I want you to just get your best guess. Is this patient sick or not sick? You can be wrong, and it's good to be wrong. You'll learn more by being wrong, because if you say, wow, I really thought this patient was sick, but at the end of the day, we're sending that guy home and he looks great. Why was I wrong? Or maybe you thought, I really didn't think that patient was sick, but now he's intubated and going to the ICU. I was way off. What was different? What was wrong with my thinking? This is how you're going to develop those critical thinking skills, is by making a decision, making a commitment, and then figuring out why you were right or why you were wrong. So let's go through one quickly using the patient that we had up here. Okay, I'm going to try and present this patient to you in less than 3 minutes. So I would say this is a 57-year-old man presenting with chest pain. So this guy said that he was making breakfast this morning when all of a sudden he developed this sudden chest pressure. He's never had anything like this before, and it made him feel really bad, so that's why he came in today. He describes the pain as dull. It started about 20 minutes ago. It's in his left chest. It's been constant since then, about 20 minutes. It radiates to his jaw and his arm. It's worse with exertion, and it's better with rest. He's never had this before, which is why he is coming today. He has no palpitations or no nausea. He doesn't use any cocaine. He does have a strong family history for coronary artery disease. He's not had any recent surgery or travel. He doesn't have a history of cancer. He's never had a PE or DVD before, and he doesn't report any calf tenderness or swelling. He does not have any back pain or belly pain, especially nothing tearing. He's got no pain below his diaphragm. He's had no trauma. And he's not had any nausea, vomiting, or belly pain either. So his past medical history is significant for hypertension, He's had no surgery in the past. He's allergic to penicillin. He doesn't know the names of his meds, and he doesn't smoke, doesn't do any drugs, doesn't do any alcohol. His review of systems is blah blah blah. On physical exam, he generally looked a little bit sweaty, but was otherwise comfortable. His HENT exam's unremarkable. His chest regular rate and rhythm, no tachycardia, no extra heart sounds heard, no gallops, rubs, or murmurs. On his lung exams, he had no crackles, he had no wheezing, he had good air entry, his abdomen was soft, his extremities showed no edema and no Hohmann's sign. So on my assessment and plan, this is a 57-year-old man who comes in with chest pain, which is fairly characteristic of an acute coronary syndrome. I think that the probability of ACS is pretty high given the description of the pain and his strong family history. I'd like to order an EKG, which we got already, a troponin, and I think regardless he needs to be admitted, and maybe he needs a stress test afterwards if everything comes back negative. My risk for PE was pretty low. He had no risk factors for that, and so I wanted to get a D-dimer, and if that was negative, I would be done with that. Again, my risk factors for thoracic aortic dissection, I would say medium, because he does have some vascular disease and he's got this substernal pain. But I want to order a chest x-ray and see what his mediastinum looks like. Tension pneumothorax, he has no JVD, he has no tracheal deviation, he has none of that triad, he's got no hypotension, and he's got no decreased breath sounds on any side. So I'm not going to order any tests for that, and I also don't think it's esophageal rupture. He's not been vomiting. And so I also wanted to order a CBC and a CMP. So my best guess at a disposition for this patient would be that we would admit him because I think he needs to be ruled out and stressed. That's it. Thank you.